Hi, good morning, everybody, and Assalamu alaikum. It gives me a great pleasure to start the first session of the second day of 21st Shaukat Khanum Symposium. We're starting with the HPV Oncology session, and we have got a star-studded faculty today. So I welcome our standard faculty who will be talking for next 2 hours, and looking forward to that talk. Lots of people could not join us in person because of sad incident which happened 2 days ago. But they are present online. So all the colleagues are present online. Could you post your questions in the chat box and we'll answer them at the end of every talk. So I would like to welcome Professor Gareth Morris-Stiff, who's going to talk about enhanced recovery after surgery in HPV surgery in context of Pakistani healthcare system, which is resource deficient. I've known Gareth for many years. We both were together at the same time when we were doing training. Then he left UK for America, and currently he's working as professor of surgery in Cleveland Clinic, Ohio. He's a seasoned academic and has written extensively on almost every topic in HPV surgery. So looking forward to talk by Gareth. Gareth could not make it in person today. I wish he was here with us today, but he's present online and he will take questions live at the end of the talk. So can we start Gareth's presentation, please?
Good morning. My name is Gareth Morris-Stiff, and I'd like to share with you today a few thoughts on the role of ERAS in pancreatectomy. My talk will be divided into 4 sections. Firstly, what is ERAS? Secondly, what is the evidence for ERAS? We'll then follow this with my ERAS experience. And finally, I'd like to address the issue of introduction of an ERAS protocol into a resource-deficient healthcare system. ERAS itself is a misnomer, as much of the good work starts long before an operation takes place. The Dane Henrik Kellett was the first to think about the process of ERAS surgery, which he termed fast-track surgery. The ERAS study group was formed in 2001, and less than a decade later, the ERAS Society had been established. The goal of an effective ERAS program is a rapid return of the patient to normal life function. Now, this is really what they were like before their illness. In the case of patients with cancer, another important consideration is the use of postoperative therapy. And therefore, ERAS should aim to get the patient to the chemotherapy or radiotherapy as indicated as quickly and as efficiently as possible. There are 2 ways of looking at the principles of ERAS. Firstly, is to look at enhanced recovery as being supported by several pillars, as you see here, and based on sound patient education and engagement. This is sometimes called the Parthenon model. I prefer this one, in which patient care is centered around effective pre, intra, and postoperative care. This I could term the Mickey Mouse model. As I just mentioned, patient care is paramount, and the aims of ERAS is to provide a multidisciplinary care pathway, which through standardization of care leads to optimal outcome on every occasion. There are numerous guidelines available, and these I'd like to highlight and recommend to you from the 1919 Consensus Conference published in 2020. There are 3 important areas to ERAS, as I mentioned earlier: preoperative, intraoperative, and postoperative care. I'm sure you'd all agree these factors listed here are nothing special in the main. Most of these are standard factors you'd like to assess before any operation. And also then intraoperative and postoperative factors, which you would apply to all patients. There are a number of important elements that I think are important in pancreatectomy in particular. Enzyme replacement therapy, immunonutrition, and carbohydrate loading. Enzyme replacement therapy is key in establishing a good nutritional basis for the patient, and this with the supplementation of these other factors. We used to use ClearFast and but this is rather an expensive agent. We've switched this now to simple electrolyte replacement with Gatorade. I want to spend one moment explaining my thoughts on enzyme replacement therapy in pancreatic cancer surgery. We studied a group of 327 patients undergoing pancreatoduodenectomy and divided them into whether they had no enzyme replacement therapy, post-operative enzymes only, or combined pre- and post-operative enzymes. Diagnosis of EPI was seen in 239 or 73%, and it was based on either dilated pancreatic duct or the presence of symptoms. So you can see an anatomical obstruction of the duct is present far more commonly than symptoms indicative of physiological dysfunction. When we look at the results of this retrospective analysis, we showed that there's significant reduction in the rates of pancreatic fistulae, both in total and in the clinically significant groups, when enzymes were given both pre and post-operative. The benefit was also seen in fistulae in terms of giving post-operative enzymes, but this was not as significant. The incidence of surgical site infection was also significantly reduced, particularly when enzymes were given preoperatively. So the administration of enzyme replacement therapies to patients with exocrine pancreatic insufficiency before surgery leads to a significant improvement in post-operative recovery. Another important element is frailty assessment and prehabilitation. This purple line shows a typical course of a patient who, before their illness, in this case, development of pancreatic cancer, are in a reasonable premorbid state. With illness comes a dip in functional status. This may stabilize preoperatively. For sure, there will be a dip at the time of surgery, and the aim is to get the patient back to the premorbid state as quick as possible. With intervention in terms of ERAS, following an illness which leads to an inevitable dip in functional status, if ERAS is applied appropriately, then the patient may return to the premorbid status ahead of surgery. This leads to a lesser dip in the level of dependency and a quicker return to premorbid status. Sadly, there are a number of patients who don't return to the premorbid status after surgery. These are the ones that have the worst outcomes. In terms of assessment of frailty, there are a number of factors that we assess. Simply is, and first off, is the weight loss as described by the patient. This is reasonably useful to give us an indication of the severity of the weight loss. We use a handheld dynamometer to gain an indication of grip strength. A get up and go test in which a patient stands from sitting, walks 3 meters, turns around, walks back and sits down. And also the Charlson Comorbidity Index, which in our hands, we feel gives a good indication of the severity of the premorbid state. Prehabilitation is very easy to deal with. In the simplest terms, working in the gym under supervision with a physiotherapist or a personal trainer can help. We've been looking at a far more complex system in which we can train a group of patients with the data being recorded continuously and a personal program identified for each activated by an Apple Watch. Early mobility and center spirometry are also key to the recovery after surgery. We get our patients walking around the day of surgery, and we find that this certainly helps. Early nutrition, in our protocol, post-operative day 0, we start putting water down an NJ tube, and this we place intraoperatively in all patients undergoing pancreatoduodenectomy. On post-operative day 1, we commence a clear liquid diet, move on to a full liquid diet on day 2. If there have been no complications, a solid diet and recommencement of enzyme replacement therapy starts on day 3. So within 3 days of a pancreatoduodenectomy, our patients are on solid food. These factors are also very important: post-operative day 1 amylase and early drain removal. The use of POD1 amylase to predict the development of pancreatic fistula has been well validated, disallowing early drain removal and preventing the complications associated with the presence of adrenal. So evidence for ERAS. I'm going to take you through 2 papers, and I will do so quickly. The slides will be available for you at the end of the presentation, so you can go back and look in more detail. This first meta-analysis was from Wang and colleagues in 2020. It looked at a total of 3 randomized control trials and 19 non-randomized studies from around the world and graded them appropriately. In all of these subsequent graphs, you will see forest plots with the one indicating no difference between treatments. To the left will favor ERAS, to the right will favor conventional therapy. The studies are listed here, and the risk ratios are shown. As you can see, for overall morbidity, there's a definite benefit to ERAS. Again, for minor morbidity. For major morbidity, it's closer to the 1 line, and so a possible overall benefit in terms of major morbidity. Postoperative pancreatic fistulae are certainly at a reduced incidence in ERAS, delayed gastric emptying, surgical site infections, incisional, and organ cavity. The length of stay, as anticipated, would be reduced in ERAS. The 30-day readmission rate, it straddles the 1, which you may think is bad. However, what we're saying here is that we can introduce all the benefits that I've said up until now without an increased readmission rate. So that's a key point here. Mortality is beneficial with reduced mortality in ERAS. This is an early postoperative mortality. The second paper is more recent, from 2022. I want to mention this again briefly because it includes a couple of other practical factors. This study, there were included a few more RCTs, 2 additional introduced in that last couple of years, and a few more non-randomized studies. Here we see the time to liquids, again, using the same model with significant benefit for ERAS. Same for time to solids, time to passage of stool, time to removal of NG tube. Now this, I think, is a little controversial, as most ERAS protocols would indicate that NG tube should not be placed, and we certainly don't use an NG tube postoperatively. Another benefit is a quicker return or transition to chemotherapy following surgery. So there is good evidence to suggest that ERAS in pancreatectomy patients will lead to an earlier return to chemotherapy if this was part of a neoadjuvant regime or the commencement of adjuvant chemotherapy, if that was the case. This clearly has an oncological benefit to the patient and will probably lead to significant improvements in terms of survival for these patients. One concern is that the early introduction of diet leads to increased incidence of car leaks. This one retrospective study with a large patient cohort demonstrated that certainly early oral intake is not associated with the incidence of car leak. Of benefit was that the ERAS group had their car leaks identified earlier than the non-ERAS groups. And for sure, the early oral intake did not increase the grade of the car leak and the cost of the hospital stay in relation to that car leak. Opiate reduction is an important issue, particularly in the United States, where opiate epidemic in relation to postoperative analgesia is very common. Here we see a study of major hepatobiliary surgery, including pancreatectomy, which showed a 26% reduction in the use of opiates. In our experience, around a third of patients have no opiates postoperatively. The remainder have a minimal dose of opiates. So I think that further reductions than this 26% can be achieved in dedicated programs. Cost savings are significant. The study indicates a 50% cost saving for patients undergoing pancreatectomy. This one, a greater than 10%. And this one, a more recent paper from Joliet and his colleagues demonstrated that in 4 out of 5 of the studies, there was a statistically significant reduction in the cost of the perioperative care in patients who received ERAS associated with pancreatectomy. Compliance is a very important issue, and there are in fact guidelines by the ERAS Society on how to assess the elements of the ERAS process. I wanted to show you 2 examples of compliance. This graph on the left shows in 3 colors: blue, compliance; orange, non-compliance; and red, data missing. Clearly, missing data is important and an element of the compliance process. We must make sure that data collection is 100% for all patients. It's interesting to see here that a number of these factors are highlighted as being non-compliant. These weren't a major problem in our series. What we did find is that the major issue was in relation to opiate prescriptions overnight, when medical staff not familiar with looking after our patients were covering, and when asked about analgesia, rather than following our pancreatic ERAS protocol, were introducing opiates in order to obtain immediate pain relief, rather than adequately assessing and reassessing the patients with non-opiate therapies. This graph is also interesting because it shows that ERAS compliance overall is around 60 to 65%, but importantly can be applied to all age groups. So age is not a limitation for the application of an ERAS protocol. One question I was involved in addressing was, are all surgeons participating in ERAS? We studied 236 surgeons who were all members of specialist societies. Only 61% followed an ERAS protocol, which surprised us. Analgesia was most commonly followed at 76%. Only 53% had a standardized fluid protocol. The one good element was that 87.8% had chemical prophylaxis, although not all patients received this for up to 30 days after surgery, particularly in those cases where a malignancy was present. My experience with ERAS commenced when we had a new chief at the Digestive Disease and Surgery Institute. He was very experienced in colorectal ERAS, and he wanted us to adopt it for all abdominal surgeries. As you can see, it wasn't just general surgery, but urology and gynecologic oncology were also included. In terms of HPV surgery, we felt that the hepatic and pancreatic components differed significantly, and so we split them, and I took control of the pancreatic limb. All elements of the protocol had to be based on randomized controlled trial evidence and not on personal preference or dogma. I would say that there was one exception to this at the time the work was commenced, namely that there was no published randomized controlled trial on the use of enzyme replacement therapy. And I did include this as I was well aware of 3 trials which were due to report, and I knew that the evidence was positive for all 3. After multiple team discussions, the final format was agreed, and we created what we called an EPIC Smart Set in our electronic medical record. Electronic medical records make the process of following ERAS a little easier than conventional record systems, but it's by no means a definite requirement, and paper records are perfectly adequate for documenting the benefits of ERAS. We looked at various performance metrics, including complication rates, length of stay, readmissions, and both 30 and 60-day mortality rates. Between 2014 and 2017, a 4-year period, 319 patients underwent pancreatic duodenectomy, and almost identical numbers were in the pre and post ERAS eras. I'm going to go through this data very quickly because most of it shows that there was no difference between the groups. Here we see in terms of demographics, no difference. In terms of patient comorbidities, preoperative factors. There's one preoperative factor that stands out here, and that's in relation to the use of neoadjuvant radiation. Our center was conducting a trial in the early part of the series, and more patients underwent radiation. In terms of other intraoperative factors, no difference. General complications, the reintubation rate was less in ERAS, which is probably due to an improved cardiopulmonary status in those having prehabilitation prior to their operation. Yet, in terms of general complications following surgery, here again, no difference. The important differences here come in relation to pancreatic complications. As with the other data I showed you, a reduced pancreatic fistula rate, reduced clinically relevant pancreatic fistula rate, and importantly, a reduced hospital stay. Pre-ERAS was 7 days down to a median of 6 days. For my patients, in which I was reviewing twice daily, I had my median hospital stay reduced to 3.5 days for an open pancreatic duodenectomy. So I think that, as I will come on to shortly, there has to be a high degree of dedication to the system. If we compare our ERAS results with the national data, National Surgical Quality Improvement Program data in the US, we see that in most areas, our complication rates are reduced or almost identical to the national levels. So we can be confident that our ERAS program is benefiting our patients in multiple different ways. So what else did we want to look at? We're going to follow this up with patient satisfaction data, measuring compliance to the procedures associated with ERAS, and also an assessment of opiate reduction, because this is a very important area, particularly in the US, as mentioned. So what about ERAS in a resource-deficient system? Are there really any barriers to ERAS? And if so, how can they be overcome? I'm going to return momentarily to this slide you saw earlier. And if you look at each of these factors, really there's not one that requires a high expense. And almost all of these will be already in your practice. So it's just a matter of turning them into a systematic approach that all patients have all of these factors assessed and operated on. In terms of nutrition, I was able to find that Creon is available in Pakistan. It is, as it is in the US, a very expensive drug, but I think the outcome data that I showed you would indicate that it may well be worth the additional expense and that the expense is offset by benefits to both the hospital system and to the patient. If we look at the area previously occupied by immunonutrition, I think you have a huge benefit in all of the fresh fruit and vegetables, more importantly, the lack of processed foods. And I honestly believe that good nutrition, when present, means that the immunonutrition is an option, but not an essential element. Likewise, with the preoperative carbohydrate loading and electrolyte balance, a good fruit juice with the essential vitamins and electrolytes present is probably better for you than the Gatorade that we are using. There's one element I would stress to you, and that is you must speculate to accumulate. I've heard this said many times, but I could not find any direct reference, so I'm attributing to myself now. So implementing an ERAS system, what's involved? Well, there are 3 elements. You must have a supportive environment with the management and senior staff willing to assist the process. You must have doctor and nurse champions. I was our medical champion, and we had a nurse on our regular nursing floor who helped coordinate with her staff and make sure that the ERAS factors were being followed in each of our patients. We must educate other healthcare professionals that are associated, not just our own teams, because often there is cross coverage. If they don't know the rules, they will not be able to comply. So what are the costs of creating an ERAS program? Well, this program, colorectal program here, identified the cost over $500,000. However, the savings were close to $1 million, and therefore close to $400,000 saving. Now, I'm not suggesting you have to spend this money, because this is on the systems in the US are a lot more expensive regardless. What it does show here is that by investing a little money up front, within a year, there are significant savings, and these savings continue year on year as long as the ERAS is followed. So return on investment. Does operating an ERAS policy lead to savings? Well, this paper would suggest so. This is from a enhanced recovery program implemented in Alberta, Canada. It looked at the return on investment across the board in numerous centers and noted that these were between 1.05 and 7.31 for every dollar spent. So for every dollar spent, there's either $1.05 or $7.31 in return. So even in the worst case scenario, you are gaining money. This study demonstrated that the probability of ERAS being cost effective was in the order of 86 to 99.9%. So it's almost impossible for it to fail. One factor that they didn't elaborate on, but which published in their data, is the fact that mortality at 1 year was significantly reduced in the ERAS group. I would say that whilst this study was not specifically for pancreatectomy, I would say that the reduction of complications post-operatively, as well as in pancreatectomy, the opportunities of returning to chemotherapy are probably what drives this mortality down. So this is evidence that ERAS reduces not just short-term, but also long-term mortality. So to conclude, ERAS is applicable to pancreatic surgery for certain. Nutrition and enzyme replacement therapy are very important elements. There is evidence that pancreatic ERAS is effective in reducing complications, is cost-effective, and much, much more. And I would advocate that ERAS can be safely introduced into a low-resource healthcare system with minimal additional expenditure. Thank you very much for your attention, and I'm happy to address any comments you may have via email over this next couple of weeks. Thank you. Bye.
Thank you very much, Gareth. I think Gareth is present online, so we'll open up the paper for any discussions. Any questions from the floor?
Thank you for very nice and comprehensive talk on the complicated theme here, and that's evidence to show there. We also use ERAS and Shaukat from Oslo, Norway. Worked with Christopher Lassen, who was some of the papers you showed. And I have just a question about the ERAS patients, and what about adjuvant chemotherapy? Is that proven as well, that more patients get adjuvant chemotherapy after their PDs?
Yeah, I mean, thank you for that question. And yes, I would suggest that the adjuvant chemotherapy, the return to following a combined pre-post-operative neoadjuvant or a de novo adjuvant therapy is definitely reduced. And I think this is a lot to do with the reduction in complication rates. We found a reduction in fistula rates and surgical site infections, and I think when oncologists see their patients see our patients post-operatively, surgical patients post-operatively, having a fistula, an active fistula or a wound will delay it'll delay their willingness to commence chemotherapy. So I think that overall, getting a stronger patient preoperatively via an ERAS policy is definitely an oncological benefit. I know Professor Keith Roberts in Birmingham and his team there have done a lot of good work in this space and demonstrated this, that enzyme replacement therapy and nutrition do lead to enhanced oncological outcomes. So I think this is a definite point. It needs proving in randomized controlled trials, but I'm sure it's a valid point.
Gareth, one question from me regarding drains. So
Yeah.
minimal use of drains. So I'm the one who's guilty of not using drains in some of the pancreatic resection patients. So how you're going to convince surgeons to use minimal drains or no drains in a major resection like a Whipple's operation?
Well, I think that there's a lot of data from the US using pancreatic and Europe. I mean, the pancreatic risk score was devised in Europe, and it's spread to the US, and Chuck Vollmer did a lot of good work as well from the US side on the use of drains. And as you say, sometimes avoiding drains altogether if your risk score is very low, or if not, depending on the day one amylase. If the day one amylase is low, it predicts it predicts it's going to be unlikely to be elevated on day 3, in which case the drain can be pulled. So we do days 1, 2, and 3 amylase and follow that. We validated it ourselves and shown that that indeed is the case, that it's safe to remove the drains on day 3. So we do that in the vast majority of our patients. So I think there's a great volume of data now to support that practice, and I would advocate that it's beneficial to do so. And I think as time moves on, there will be more push to not put drains at all. I know an NG tube is not quite the same as a drain, but as I've mentioned in my talk, we don't use NG tubes at all. No NG tubes at the end of an operation. We use an orogastric tube during the operation, but at the end of the operation, it's pulled. So less plastic, the better.
Thank you very much, Gareth, for such a fascinating talk, and thank you very much for staying up late.
No problem. My pleasure, Irfan.
Thank you. So we'll move on to the next talk. Thanks, Gareth. So the next speaker is Professor Paula Kane, and she's staying up early in the morning in UK. So thank you very much, Paula, for being online. So she's going to talk about the role of neoadjuvant chemotherapy versus upfront surgery in a low middle income country. We all know Paula as being heavily involved in ASPEC trials, and she has recently published the landmark ASPEC 5 trial, which should be out in print very soon in Lancet. Looking forward to hear Paula's thoughts about use of neoadjuvant chemotherapy here, where it's an expensive hobby to give both neoadjuvant chemotherapy and then surgery in a resource-deprived country. So we are going to run Paula's recorded talk, but she's online to answer any questions at the end of her talk.
Firstly, I would like to thank Irfan Ahmed and the organisers for their very kind invitation for me to speak today at the meeting. My name is Paula Kane. I'm a pancreas surgeon in Liverpool, and I want to be talking about the role of neoadjuvant therapy versus upfront surgery in pancreatic cancer, with special emphasis on low and middle income countries. If you look at the projected global cancer cases by 2030, you can see that approximately 3/4 of all cancers deaths will occur in low to middle income countries. And in those countries, 1 in 8 people will experience a cancer diagnosis in their lifetime. So that will represent a considerable disease burden. So this will be pivotal in trying to cope with this rise in cases. So this particular study in Nature Medicine looked at the 5 key research priorities for low to middle income countries over the next decade to help improve outcomes for pancreatic cancer. And some of these we'll touch on later in this talk. So there was a key research priority of reducing the burden of patients presenting with advanced stage disease. So if we can increase the early diagnosis, that would be beneficial. And obviously to improve access and affordabilities in cancer care. To emphasise health economic assessments of cancer interventions, and also to scale up quality improvement and implementation research in cancer control, and also to use technology and technology innovations to improve cancer control as well. So certainly in looking at various treatment options in low to middle income countries, research priorities can help facilitate those particular changes. So if you look at the worldwide burden for pancreatic cancer, we can see there's a range of intensity of cases around the world with the burden in high income countries. But again, there are considerable burden in low income countries as well. I'm really going to concentrate on neoadjuvant trials and the evidence for neoadjuvant therapy at the present time. And then I'm going to focus on how we can focus on that in low to middle income countries and look at the challenges and possibly some ways to overcome those challenges. So the first study I'm going to look at is basically focusing on resectable and borderline resectable disease. And that's about 20 to 25% of cases. And as you can see, this depends on the involvement of the vasculature. And there are a number of international classifications which are involved in defining borderline resectable disease. So one of the first studies we can look at is the Dutch Pre-Panc study. So this was a randomized study looking at 246 patients, and they were randomized to receive either immediate surgery or gemcitabine radiotherapy. The initial analysis had a primary outcome measure of overall survival, and the initial planned analysis did not find any significant survival difference between neoadjuvant therapy and surgery. However, the long-term results, which you can see here, of the Pre-Panc study, show that there was a survival advantage for neoadjuvant therapy. And when they looked at the subgroup analysis, they found that this survival advantage was seen mostly in those people who had borderline resectable disease. So for this trial, they identified that borderline resectable patients had the most benefit from neoadjuvant therapy. Although we have to acknowledge that the median overall survival times were quite poor for all groups in this particular study. So the Alliance study was looking at preoperative FOLFIRINOX or preoperative FOLFIRINOX plus hypofractionated radiotherapy, and this was in borderline resectable disease. The Pre-Panc study looked at borderline and resectable. Here they randomized 126 patients to receive either neoadjuvant FOLFIRINOX or neoadjuvant FOLFIRINOX plus radiation. The primary outcome measure was 18 months overall survival, and they compared that with historical controls. And for efficacy, it needed to be over 50%. And they found that this was reached with the FOLFIRINOX group, but not with the FOLFIRINOX plus radiation. So again, we have some conflicting evidence in terms of the use of radiation in patients with pancreatic cancer receiving neoadjuvant therapy. The JASPAC-05 trial looked at neoadjuvant chemotherapy, and here they used gemcitabine and S1 versus upfront surgery, and this was for resectable pancreatic cancer patients. They looked at 362 patients, and these were randomized, and what they found was that the median overall survival was better for those patients who were receiving gemcitabine S1 neoadjuvant therapy when compared with upfront surgery. However, we must acknowledge that the use of S1 in populations outside Japan has not been fully explored, but this could be an option for patients with resectable disease undergoing neoadjuvant therapy. We then can look at the SPAC-5 study, which was coordinated from Liverpool. We were recruiting people with borderline resectable pancreatic cancer. So we randomized 90 patients. And here we wanted to see the feasibility and efficacy of using different types of neoadjuvant therapy. So in this study, patients were randomized to either receive immediate surgery or gemcitabine capecitabine neoadjuvant therapy, or FOLFIRINOX, or chemoradiotherapy with capecitabine. And these were all short course chemo or radiotherapy regimens. So they were for 8 weeks. They then underwent restaging, and if they were felt to not have progressed or developed metastatic disease, they underwent surgical exploration. Those patients who were able to undergo a resection had adjuvant therapy according to patient and clinician choice. So the primary outcome measures for this study were feasibility, as at the time of study design and conception, neoadjuvant therapy was not standard practice in the UK. But we also wanted to incorporate efficacy outcomes as well, and you can see those listed in the box on the slide. So we used a fairly standard borderline resectable criteria, as you can see here. So there was loss of normal tissue plane between the tumoral vessels, some form of venous involvement, plus or minus arterial involvement, and no evidence of metastatic disease. So the two primary outcome measures were recruitment rate and resection rate. We found recruitment was a challenge for this study. As I said, it was a major change to the patient pathway, but the concept of neoadjuvant therapy became more acceptable over time, and therefore recruitment did pick up towards the middle and end of the study. We didn't find a difference in resection rate between immediate surgery and neoadjuvant therapy groups, so there's no significant difference found there. And this was also reflected in the R0 resection rate. There's no difference. However, you can see that the neoadjuvant therapy group did have a higher R0 resection rate, although this wasn't significantly higher. If we look at the outcome measures in terms of efficacy, look at overall survival at 1 year. And what you can see is that those patients who had neoadjuvant therapy, which is the black line on the Kaplan-Meier, showed a significant survival advantage to those having immediate surgery. And the hazard ratio there was 0.29. If we looked at the individual neoadjuvant therapy arms, we can see that FOLFIRINOX had the best survival, that's the green line. Then was gemcitabine, capecitabine, that's the red line, and then chemoradiotherapy. So in conclusion from our trial, we found a difference in resection rate between immediate surgery and neoadjuvant therapy. However, there was a significant survival advantage at 1 year for neoadjuvant therapy. We found that FOLFIRINOX appeared to be the best combination. However, toxicity was higher in that particular arm. So our conclusion was that neoadjuvant therapy should be considered for patients with borderline resectable pancreatic cancer. So if we look at the evidence so far, including our study, these are all the studies that had immediate surgery versus some form of neoadjuvant therapy. And they included resectable and borderline resectable disease. And we can see there's a variety of different neoadjuvant therapy regimens, and also these are also different periods of regimen as well. So if we look at the meta-analysis of all these particular studies, we can see at the bottom, those are the borderline resectable patients and studies. And as you can see, there's a survival advantage, which is significant for those people who have borderline resectable disease to receive neoadjuvant therapy. However, for resectable patients, the outcome wasn't as clear-cut and it wasn't significant. So certainly the conclusion from the evidence we have so far is that neoadjuvant therapy for pancreatic cancer is beneficial for borderline resectable disease. However, the NICE guidelines in the UK, which were published in 2018, say that we should only consider neoadjuvant therapy for people as part of a clinical trial. But I suspect that these will be updated in light of the evidence and the weight of evidence that we now have. So in conclusion, there was a survival advantage for borderline resectable disease, no convincing survival advantage yet for resectable disease. The use of combination chemotherapy is effective, with mixed evidence for chemoradiotherapy, and certainly more studies are needed to identify further and better regimens and the duration time that this should be given. So what are the challenges in delivering optimum neoadjuvant therapy in low and middle income countries? So in order to deliver neoadjuvant therapy, and here we're talking about borderline resectable disease, histology is required prior to starting, so you need availability of EUS and biopsy. Obviously accurate staging with triple phase CT. One issue is there are less numbers of tertiary centres with high surgical volume. And also there's a lack of ability to deliver intense chemotherapy regimens and the support needed to deal with the complications and toxicity. Short course radiotherapy may be more feasible, but more focused and intense radiotherapy can be expensive. And some patients may improve following neoadjuvant therapy such that they don't want to undergo any further planned surgery. So are there particular treatment options that might be more acceptable or feasible in low to middle income countries? Well, single agent regimens are probably going to be more feasible with short course radiotherapy, although there is some question marks still about the use of radiotherapy. In SPAC5, we did use combination therapy, but it was short course, 8 weeks, so that might be an option. And then other more straightforward chemotherapy options such as S1 might be possible, although again, the use of that outside of Japanese populations is still to be proven. So are these possibilities for low to middle income countries? So how can we overcome the unique challenges and optimize the care pathway? well, the centralisation of care with performance of the complex pancreatic surgery at high volume centres, and also to enable local centres to undertake less complex procedures and also partake in the day-to-day care of these patients, to institute timely review and audit of outcomes, and also the use of telemedicine and technology to improve communication and collaboration, and also trying to identify earlier diagnosis through the use of screening of high-risk populations. So I think we've seen the evidence for neoadjuvant therapy, particularly in borderline resectable disease. I think we've identified some of the challenges in low to middle income countries and how these might possibly be overcome. Thank you very much.
Thank you, Professor Ghani, for giving this beautiful talk on such an important topic. As to know is that, can you hear me?
Yes, thank you. It's I am awake. I can confirm I am awake.
Sure.
And I am here. I'm just going to put my video on now. There we are. Morning.
Question is, what was the disease progression rates in patients who were borderline resectable? My worry is those patients who are borderline resectable but potentially resectable. For example, if there is portal venous involvement but SMA is, and if I take them to the course of neoadjuvant chemotherapy, I know they are potentially resectable. I think some of them will progress while on chemotherapy. So what was the rate of progression of disease in those patients in this study or in your experience? That's my first question.
Thank you. Yeah, I mean, obviously it's always a trade-off with neoadjuvant therapy when you're thinking about what proportion of patients will progress under neoadjuvant therapy and therefore not be able to undergo surgery. I think one of the key findings from our trial was that we saw that there was no difference in resectability rates between the two groups. So it was around 50% for both groups. However, the survival in the neoadjuvant therapy group was much higher than that of the surgical group. So what we thought that was a very interesting finding, because it kind of showed that the delivery of the neoadjuvant therapy appeared to be an important factor, even for those patients who couldn't undergo surgery. So we felt that sort of outcome held true, even for those patients who weren't able to undergo surgery and progressed at their staging following neoadjuvant therapy. So I think it's difficult, but I think that was one of the main findings of our study, that even though patients did not have a resection due to progression, the survival outcomes were better in that particular group of neoadjuvant therapy. So again, it's a question that needs looking at. And there's a trade-off between, I mean, our study had short course neoadjuvant therapy, so it's 8 weeks. A lot of other studies have at least 12 weeks or longer. So again, there's a trade-off between length of neoadjuvant therapy as well, and when you time your surgery. So again, it's further work needs to be done in that area, just to try and identify optimum timing and optimum regimens as well. So, but for our study, we found that neoadjuvant therapy did hold a survival advantage even for those patients who didn't have a resection.
Paula, great to listen to you like always, and thank you very much for staying up that early. I know it's just after 4 o'clock in UK. One question, as you know, I've been here in Pakistan for the last few months, but what I feel is here we are dealing with a much younger group of patients. So our pancreatic cancer resection is usually done in patients who are in their 40s and 50s. And I feel that's a different group of patients which we see in the West. So it is just a comment. I think we follow all the evidence which comes from the West, where we have got robust systems to run all these trials. But the population of the patient here is different, and they may not be following the same type of response to these treatments which we're talking about. So my comment is, I think we need to get the Eastern countries in the East involved in these trials to get more evidence, which might be different from the data which comes out from the West. I don't know what your thoughts are on this.
I think you're absolutely right. And that was that Nature Communication paper at the start showed that, you know, research priorities in low middle income countries is so important to sort of underpin any progress in cancer control and therapy. So, and also it's always the case of how applicable are trial results to the patient population and health service of countries around the world. So I think you're absolutely right that to involve low and middle income countries and collaborate in studies going forward will be really vital to that sort of achievement, I think. So I think you're absolutely right, Irfan.
I think we need to talk about that outside this conference at some point.
Indeed.
Thank you very much, Paula, for this fascinating talk. So, so you can go back to sleep again if you want to, or you can stay online listening to.
I might do half and half.
Thank you very much.
Okay, bye-bye.
Next talk, which is Robert Sutcliffe. He's a friend and a colleague who's a consultant surgeon from Queen Elizabeth Hospital, Birmingham. So I've asked Rob to talk on a very difficult topic, which is pancreatic fistula. That's a nightmare for pancreatic surgeons. We all hate to have it, but all the pancreatic surgeons have it, and many of the patients. So Rob, over to you. How we should deal with this problem.
Thank you, Irfan, and the organising committee for inviting me to give this talk. Before I start, can I have a show of hands, please? How many pancreatic surgeons are in the room? And keep your hands up. A few. Now, can you keep your hand up if you have never had a pancreatic fistula? This chap, no? You want to come and do the talk? So I think we all recognise it's a big issue. So I'm going to talk about risk factors for pancreatic fistula, and I'm going to focus the talk on pancreaticoduodenectomy, which is where really the problem is. Obviously, fistulas occur in distal pancreatectomy and other scenarios, but it's in a Whipple's procedure that is where there's major concern about the impact of the fistula. So risk factors, then mitigation factors, and a bit about the learning curve of pancreatic anastomosis and how we might reduce or prevent pancreatic fistula, and then post-operative, once you've how to diagnose it, how we treat it. So pancreatic fistula after Whipple's is common. The majority, thankfully, are biochemical, but clinically relevant fistulas have an impact that cause sepsis, organ failure. They require interventions that are associated with worse outcomes. So ITU stay, prolonged hospital stay, readmission, mortality. So it's a big issue. And there's also some data to suggest that fistulas affect long-term outcomes, partly due to reduced opportunity for patients to get adjuvant chemotherapy. So the definition, so it was the ISGPF group which defined pancreatic fistula, and they revised their definition in 2016. So it's defined by a drain fluid amylase on or after the third post-operative day, which is greater than 3 times the upper limit of normal. And they differentiated between a biochemical leak where a patient is clinically well but has amylase-rich fluid in the drain versus a patient who is unwell and needs intervention. And where there's a change in management, and that's a B or C fistula. The C is more severe, where surgery, reoperation is required, and there's a worse outcome, there's organ failure or mortality. There are some limitations with the ISGPF definition, in that it can only be applied retrospectively. So you can look back at your database and say, yes, we've had X number of grade B fistulas, but it's not helpful in terms of management of an individual patient. The grading of the fistula is influenced by the treatment you give for the fistula, and that can differ between centres or between surgeons. So you can't use the system to guide your treatment. And there's a heterogeneity of the grade B fistula in particular, where a grade B could be just to leave the drain in for 3 weeks, becomes a B, or you need percutaneous drainage. And a few papers, including this paper by a group in Verona, they subclassified B fistulas into B1, 2, and 3, and they demonstrated different clinical and economic outcomes between B1, 2, and 3. The risk factors, some of the risk factors are well recognized. Body mass index, factors related to the gland, so the diameter of the duct, the texture of the gland, and the disease process. Intraoperative blood loss affects fistulas, and there are certain sort of technical aspects that may influence fistula incidence. And I'm going to come on to the learning curve for pancreatic anastomosis in a few slides. Several risk scores have been developed, which I'll come on to. And there are certain factors that are potentially modifiable that may or may not reduce or prevent pancreatic fistula. I'll come back to that. So the 3 risk scores. The first one is the FRS, the fistula risk score, which included pancreas factors, patient factors, but it also included some subjective elements, including texture and blood loss, which is difficult to monitor accurately. The Birmingham fistula score was a UK multi-centre study which included only 2 objective factors, so the PD width and the BMI, and then the alternative fistula score was a progression from the original fistula risk score, excluding texture and blood loss. So we did a study in Birmingham looking at the learning curve for the pancreatic anastomosis. So we compared the learning curve of 3 of our, at the time, 3 of our established consultants and 5 newly appointed pancreatic surgeons. And we used QSIM analysis, which is a fairly well-established method to look at learning curve. When you're doing QSIM analysis, you need to pick an endpoint, and the endpoint we used wasn't just fistula, it was risk adjusted using the risk score that we previously developed. And so we looked at the incidence of fistula over consecutive pancreaticoduodenectomies for all of the surgeons, and we demonstrated that established surgeons had a significantly lower fistula rate than newly appointed consultants, and you'd expect that. We also quantified the learning curve, which was interestingly around 50 to 70 procedures. Now in the UK, in a high volume centre in the UK, the average pancreatic surgeon would do maybe 15 or 20 Whipples a year. So this means you'll be on your learning curve for the first 2 or 3 years. So lots of studies, a lot of data on which anastomosis. Bottom line is there's no single anastomosis which is better, and I think it comes down to the learning curve, which I've just talked about. This meta-analysis of randomized trials compared different anastomoses, 15 trials, big numbers of patients, and they demonstrated a low rate of clinically relevant fistula with a PG rather than a PJ. PG is much less commonly used generally, but you have to look at the limitations of, although this is high-level evidence, there's limitations to this data. You need to understand the limitations to interpret the data, because looking at this data, you think, well, we should all be doing PGs, but it's not the case, because PG, the comparison was only done in 2 of the RCTs within the trial, and it didn't take into account the learning curve. So you may have compared somebody with experience doing PGs versus a novice doing PJs, so, and there was no risk adjustment of the outcome. So you didn't take into account the pancreatic texture, the pancreatic duct width, BMI, and things like that. So you have to understand the issues with the individual trials. So coming on to mitigation, can we reduce the risk of fistula? Can we prevent fistulas? And I'm going to talk about these 4 specific components. Many of us use octreotide or other somatostatin analogues, but really there's no data to support that. And again, meta-analysis of 12 trials, over 1,600 patients, no benefit for somatostatin analogues in terms of clinically relevant or overall fistula rate or mortality. You cannot recommend somatostatin analogues routinely in patients with after Whipples. pancreatic duct stents. So this was a meta-analysis of looking at interventions that may reduce pancreatic fistulas after Whipple's. And in this study, we looked at 12 interventions. None of 55 randomized trials, 7,000 patients. And the main finding of this study was that most of the trials were underpowered to identify a difference. I picked out 3 important bits of data that we found, that external PD stent was associated with a reduced fistula rate, even though it's not that widely used. I don't know how many surgeons in Pakistan use external stents, but not very widely used in the UK. A type of olenistatin, which is a type of somatostatin analog, in one trial showed a reduction, and there was some suggestion that an invaginated PJ reduced fistulas compared to duct to mucosa. But again, the limitations of the trials. So drainage, we talked about drainage during Gareth Morris-Stiff's presentation. So should you routinely drain a patient after Whipple's? 3 randomized trials. The first one by Khanum, they demonstrated a reduced fistula rate, but no difference in the primary endpoint. So in other words, they felt it was safe not to put drains in. The second trial, Van Buren et al., was stopped early due to high mortality in the no drain group, so 12% versus 3% 90-day mortality. But a further trial, which was a slightly bigger trial, where the primary endpoint was reintervention rather than mobility, demonstrated no difference in the endpoint, but did identify a reduced instance of clinically relevant fistula in the no drain group, which is interesting. Rather than not leaving the drain, you can take the drain out early. So in patients who are low risk of a pancreatic fistula with a low DFA1, and after excluding the fistula on DFA3, you can take out the drain early. So Bassi from Verona did an RCT on this topic. They demonstrated reduced fistula rate in patients who had a drain taken out early. So I don't understand the pathophysiology of that. I don't understand why taking the drain out would prevent a fistula, but I think it's to do with, at the time, 2010, this was before the revised guidelines, the revised definition. So by taking the drain out early, you're not diagnosing the biochemical leaks. But they found it was safe to do that. And in the second trial, so a much bigger study looking at major morbidity, no difference between early removal versus late removal. So it's a perfectly safe thing to do. And that's what we do. So nutrition, it's a dogmatic approach is to starve patients after Whipple's, which is clearly not in the patient's best interest. And lots of studies have looked at this. And this study was a meta-analysis of feeding patients after Whipple's. So feeding patients, letting the patient eat and drink after Whipple's, based on 4 studies. There was no difference in the incidence of clinically relevant fistula or in delayed gastric emptying. And in fact, if you feed patients earlier, they go home sooner. We introduced an ERAS pathway in 2013. Prior to that, patients were starved for 5 days. And since then, we let them eat and drink early post-op. And that is, in my opinion, that is the single most important factor in early discharge in those patients. So we've done the operation. We've diagnosed a fistula on day 3 with a high amylase. How do we manage the patient? They've got a surgical drain in. I was interested to work out whether it's possible to stratify patients on day 3, whether you can say this patient is going to go down the route of having a clinically relevant fistula. This patient is fine, they're going to stay biochemical. So we did a study to look at this topic. Biochemical leaks have no impact on patient outcomes. So is it possible to differentiate between the 2 types of fistula? I'm not sure this projects very well. So we looked at biochemical parameters for the first 7 days post Whipple's in all patients who had a pancreatic fistula. and we found that there's a divergence of the CRP, drain fluid amylase, and albumin over the course of the first 7 days. And at the point of diagnosis of a fistula on day 3, we could identify 4 factors: male, gender, DFA3, CRP on day 3, and albumin, which goes down on day 3, to develop a risk score to predict or differentiate between clinically relevant biochemical leak. We then validated that with the data from Verona. Interestingly, the risk score didn't predict clinically relevant fistulas in their group, but it predicted grade B3 or grade C fistulas. And that's because Verona left drains in as part of their policy. So a lot of their B1s were biochemical in our series, so it's different definition or different management of patients. So how do we treat patients who have a clinically relevant fistula? The basic principles: treating sepsis, so treating antibiotics, antifungals based on microbiology, organ support if patient develops organ failure, frequent use of CT scans to identify collections which can be drained radiologically. Nutrition is obviously critical in these patients, and it can be achieved by oral nutrition unless the patient has DGE, or if they're just not eating because their appetite is poor, in which case you can supplement their feeding. They don't automatically need to have parenteral nutrition, you can feed them enterally. We'll talk about the PORSCH trial, which is a protocolized management performed in the Netherlands. And once you diagnose a fistula and you're treating them conservatively, when do we intervene? Well, we drain fluid collections. If patient has an uncontrolled leak, is unwell without a localized collection that can be drained interventionally, then there's an indication for surgery. And we'll talk about whether we should do a completion pancreatectomy or not if we are going to operate on those patients. The PORSCH trial is interesting, a recent trial looking at post-operative management of patients with a fistula. So they developed a protocol which is available on an app, and they did them. I mean, the Dutch are very good at setting up randomized trials in pancreatic surgery or pancreatitis, and this is a multi-center stepped wedge cluster randomized trial. What that means is, instead of randomizing patients individually to this treatment or that treatment, you randomize centers. So and you start at standard. Everyone is on standard management, standard post-operative management, and then you randomly select a center to then initiate the intervention treatment. So they change their management, and then you move to the next center. And then by that method, you can acquire 50% of patients in a standard and 50% in the intervention treatment. So they developed a protocol for when to do a CT scan. The findings on a CT, and the CT findings were assessed by a central group of experts. Primary endpoint was a composite endpoint of bleeding, organ failure, 90-day mortality, and they demonstrated a reduction in the primary endpoint, significant from 14 down to 8%, less organ failure and less mortality using this sort of protocolized management. So if we operate on a patient who is unwell with a fistula, and we don't operate on that many patients, thankfully, because of radiology, should we take out the pancreas or not? This is a retrospective study from 9 centers, again from the Netherlands, nearly 5,000 patients. The clinically relevant fistula was 16%, of whom small percentage, 3 had a reoperation. 3/4 had pancreas preserving surgery, and 1/4 had completion pancreatectomy. And this study suggested, or there was an association between completion pancreatectomy with higher mortality of 56 versus 32%. Clearly, this is retrospective, so clear, it's likely that the patients who had a completion were probably sicker, which didn't come out in the analysis. But this is something to think about, and if you can preserve the pancreas, you probably should. So in summary, risk factors for POPF are well established. There's limited data on the impact of the learning curve in fistula incidence. There's no evidence to support routine use of somatostatins. There's level 1 evidence to support external PD stents, although these stents are not widely used. Early drain removal is safe and may improve outcomes in these patients. Early feeding is safe and does not increase fistulas. A management algorithm after PD is associated with beneficial outcomes, and completion pancreatectomy is an independent predictor of mortality in POPF. Thank you very much.
Thank you very much, Robert. Excellent talk. I think our experience here is more or less the same what you have just described, to be very honest, because if I take 2 or 3 important points here, as far as comparison of pancreaticogastrostomy and pancreaticojejunostomy is concerned, so we have been doing both of them. And main reason was just really for training of trainees as well, so that they know how both anastomosis were done. So we have data of around 200 pancreatic duodenectomies from this institution and where I work now. And I think initial patients, around 100 patients had pancreatic gastrostomies, followed by another 100 with PJs. And when we recently analyzed all that data, I didn't really see any significant difference in terms of outcomes of pancreatic. It didn't. So I think there are different other factors which you described, texture of pancreas and size of the pancreatic and all that. However, although I have not yet properly analyzed the data, but gross looking at pancreaticojejunostomy data is showing that perhaps usage of an internal stent helps the anastomosis, especially if it's a pancreaticojejunostomy, but it's not a randomized controlled trial, so I really can't be 100% about it. As far as sandostatin is concerned, yeah, I think even the initial data was all very controversial, and now less and less people are using sandostatin for that purpose. And another thing, as you said, when I started here, I was trained in Leeds, and when I moved here, so I saw the same practice that people were kept nil by mouth for 5 days, and then they start feeding. So I started feeding them on day 1. So, and initially it was very difficult to convince everybody in the team that they have to just come. We used to we still put NG, which is taken out on day 1. So it was very difficult to convince people to take the NG out on day 1 and start feeding them. But what we and everyone else saw that, it really works, because average discharge day by this ERAS protocol is around 5 to 6 days for all these patients. So I think I really had these comments because it was very nice talk. I don't think I have to question them.
There's just a question from online that pancreatic texture poses the risk of pancreatic fistula, and why?
I think from a simple surgeon's perspective, for those non-pancreatic surgeons in the audience, I describe to my trainees the pancreas is like cheese. And it depends what type of cheese, so soft cheese or hard cheese. And if it's soft pancreas, the suture can cut through and cause lacerations in the pancreas and cause sort of micro leaks. We're currently working on trying to develop a simulation model. We're looking at the mechanical properties of the human pancreas to see if we can replicate that in a model, because it's all very well to make a plastic model that looks like a pancreas and you can stitch it together and say, yeah, that's fantastic. But if it doesn't leak, then it's not really a model. A model needs to be able to leak, so we're looking at that. So yeah, it's just to do the choice of position of the sutures, choice of the sutures. We're coming back to the type of anastomosis. It really comes down to the experience and the learning curve. And can you reduce the learning curve by training people outside of the patient? Because during the learning curve, patients will suffer, with a high morbidity. Can you reduce that by because the pancreatic anastomosis is a part of the operation that is not often given to trainees. So most newly appointed consultants, certainly in the UK, may have done 5 or maximum 10 anastomoses. And so that you start your learning curve as a consultant. So can you change that?
One more question, there's then the last question, which is from online.
Brain leads to secondary infection of the anastomosis. So early removal of drains will hinder that infection. Do you have any comments on that, especially for the distal ones that don't put in drains?
I think that totally makes sense. I don't have any data to support it, but I agree entirely. One thing I didn't mention at all was about a recent trial using the falciform ligament. Some people use it to wrap around the anastomosis. I don't believe that's just that doesn't make any sense to me. But people use the falciform to loop around the hepatic artery and lift the artery, because the GDA stump sits in a puddle of pancreatic juice. So if you lift up the hepatic artery, you can reduce the risk of, and that study reduced the risk of secondary hemorrhage. So that was a question about the drain.
Yeah, that was a great one. The second one is we did a study on microdialysis of anastomosis, and that is maybe combined with a Porsche study that early CT scan and early detection and early intervention probably helps against the more serious fistulas. And we just finished a randomized trial called the minimum study, which we're doing up the results now. So that we see that helps.
Since we've just published our data on differentiating between biochemical and clinically relevant fistulas, we've now started a prospective audit in our department. So we stratify patients using this on day 3, and so we've now moved towards scanning patients with asymptomatic, based up with a high risk score, to see if how many additional scans and how many times it will influence management. So that's,
I think we're running short on time. There's just one last question, probably for a short answer. That any evidence of steroid use to reduce pancreatic fistula? This is a question from online. Any evidence of steroid use to reduce pancreatic fistula? This is a question from a colleague online.
I think the simple answer is no.
Okay. Thank you very much. Thanks, Rob, for a fascinating talk. Thank you very much. Moving on to our next speaker, Dr. Shiraz Yakub, and thank you very much for joining us from Norway. He's an associate professor in Oslo University Hospital, a seasoned academic in this young age. So really good to see you here in Pakistan. And he's going to tell us about the new treatment in colorectal liver metastases, where we started from there's something which is inoperable to something we resect now, and maybe we might be transplanting for these patients. Over to you, Shiraz.
Assalamualaikum, and good morning, everyone. Thank you for inviting me and all these distinguished people coming here and giving lectures as well. Well, this was a topic given to me, and in Norway we are known to transplant patients for oncological disease besides the HCC, and I'll come into that afterwards. So I have nothing to disclose. The aim of surgical treatment of colorectal liver metastasis is who can we operate, and that's the technical solution. We discussed that on MDT meetings. And the other topic is on the balance is who should we operate? What are the oncological outcomes? These are not always so easy to answer. Anyone can learn to operate, you can say that. And there are also several studies showing that different MDT meetings conclude with different types of strategy. So many options, so many motives, so many drivers, and what should our focus be? This is a patient I had in the clinics, more than 10 liver mets from rectal cancer. You see all the segments are affected besides segment 1. This was in August 2020. He was considered inoperable and started palliative chemotherapy. 2.5 years later, there was stable disease, some response, and we treated him with ALPS, with a resection. A few months later, there was a recurrence in segment 4, which was resected, and still going without evidence of disease. Next patient, colon cancer, 1 single metastasis in segment 6. which was removed laparoscopically. And just 8 months later, he had liver, lungs, and bone metastasis and died 1.5 years later. Easily resectable and hard resectable, different outcomes, not easy. Come back to the history. In 1981, there was a report showing that 155 patients treated for colorectal cancer, they found liver metastasis, but they were not removed. And the median survival of these patients were 4.5 months. Can we do better than that? The Mayo Clinic showed us that removal of liver metastasis improves survival, but we still don't know who will benefit of the surgery. There's this gray zone of patients where size matters, number of metastases, disease-free interval, age, CA. If the metastasis is bilateral, end status of the primary, are there any extrahepatic metastases? What about KRAS mutations, BRAF mutations? But previously, we had some green patients getting resection, one solitary metastasis, and most of the patients were red zone. Further on, after some years or decades, we started resecting more patients with bilateral disease, but still on recurrence or several metastases, they were not resected. And now we are really aggressive. We're resecting most of the patients. There are some red zones, but we have these gray islands in there, exemplified with these two cases. We're easily resectable, but getting early recurrence, and the hard resectable on the red zone, but still a gray zone, he had benefit of resection. So we don't know who to resect. Although the 5-year survival has improved during the time period, so from 20% to 50%. So it does help to resect these patients. What about the strategy? Should we remove the primary first and then the liver metastasis and then give adjuvant chemotherapy? What about giving neoadjuvant chemotherapy before liver resection? How about changing it around, taking the liver metastasis first, then chemo, then primary, and then adjuvant chemotherapy, or maybe chemotherapy before the liver resection? What about radiation of the primary? What about 2-step hepatectomy to remove the liver metastasis before the primary with portal vein embolization, ALPS? And what about ablation of the metastasis or hepatic artery infusion pump or liver transplantation? And what should we do with the extrahepatic metastases which are indolent? There have been written about more than 12,000 different strategies or algorithms for these patients. So we should go from multidisciplinary to personalized medicine to see to give the right treatment to the right patient. So in the workup, we should have the CT scan to look at the anatomy, extrahepatic metastasis. MRI is good to have to look at the tumor as well as the bile duct affection. PET scans, we use that basically to rule out patients not to operate, to find any other reason for not operating them, and also in high-risk patients. And we should also look into clinical risk scores, mutational analysis, response to chemotherapy, and a surgeon's gut feeling. Why doesn't the elephant develop cancer? Any suggestions? Lifetime risk for humans for getting cancer is 30 to 40%. If you have Lee-Fraumeni syndrome, it's 90%, and for elephants, less than 5%. The TP53 gene, we have 2 alleles in humans. In Lee-Fraumeni syndrome, you are missing one, so you have high risk of cancer. The elephant has more than 40 alleles, so it is protected, so genes matter. Here are some of the common mutations in liver metastasis, and I've especially pointed out KRAS, which is often used. If you have wild-type KRAS, 3-year overall survival is 81%, and the mutation is down to 50%. But still, 50% is a good survival numbers, especially compared to the first talks about pancreatic cancers. What do we have then to choose the right patients? One of the selecting tools is response on chemotherapy. In this study by Renee Adam, patients with more than 2 liver metastases with progression on chemotherapy had little benefit of surgery. So it may help us select the right patients. So what is our toolbox? We can do percutaneous ablation. We can do minimal invasive parenchyma sparing resections, open parenchyma sparing resections, hemihepatectomies, volume increasing procedures, hepatic artery infusion therapy, and liver transplant. I will come back to these points. Ablation can be done with radiofrequency or microwave ablations, open or percutaneously or in addition to resections, but no randomized controlled trials showing the result of this treatment. In Oslo, we're running a NeoComet trial now, where we're randomizing patients to either resection or ablation. We recruited 50 of 200 patients, so it will be interesting to look at the results. And now soon Sweden will be joining as well, so hopefully we have results in 2 years. Here's some pictures showing open ablations. You see the needles in the laparotomy, and on the right side you see percutaneous ablation. Parenchyma sparing resections, they used to be forbidden. You have to do segmental resections, but now it's standard of care. And we're not so, it's not a catastrophe if you do R1 resections, especially if you do vascular R1 resections. And the parenchyma sparing can be combined with ablations or local treatment as well. We have the two-stage hepatectomies with port vein embolization. We have bilateral disease. You can remove with a small future liver remnant on the left side. You can remove the metastasis in the future liver remnant, embolize the portal vein on the right side, giving hypertrophy of the FLR, and then you can do a right side of the hemihepatectomy. And there's this ALPS procedure described by Schnitzbauer in 2012, where you have massive disease in the liver and small liver remnant, and you need a quick future liver remnant augment. You can then do the resection, but you keep the vein for drainage of the diseased liver. You keep the artery and keep the bile duct, but you divide the portal vein. After 5 days, you have a FLR, which is significantly larger, and you can complete the resection. This is ALPS from our clinic. We have done maybe 50, 60 of those, but still we have PVE as the first line of treatment and ALPS as a more rescue procedure. The new kid on the block, which has actually been on the block for quite some decades at Sloan Kettering in New York, but now there are some trials going on hepatic artery infusion using chemotherapy directly into the artery. Here's Bas from Netherlands telling that it's not rocket science, but it needs to be done very carefully. They'll look at the results, and as you see here on the Kaplan-Meier curve, you can see that patients getting hepatic artery infusions are doing better than just systemic chemotherapy. We are running another randomized trial here called the Excalibur trial, where we're randomizing patients between second-line chemotherapy or hepatic artery infusion. Actually, we have another arm. We're also randomizing them to transplant. That brings me over to liver transplant for colorectal liver metastasis. It used to be crazy, but now it's real life, at least in Norway. But there are some premises. You have to have liver-only disease. You have to have the possibility to identify some robust selection criteria, which I will come back to. And the outcomes of transplantation have to be acceptable compared to established indications for liver transplant, like for HCC or for other liver diseases. And the immunosuppression should not have a negative impact on cancer-specific outcomes. So there's a selection criteria. Transplant oncology is treatment based on biological selection and individual prognostic assessment. Here are results from the SECA-1 trial, which were the first number of patients transplanted for colorectal liver metastasis. We see a 5-year survival of almost 60%. All these patients were then selected or deemed at the MDT meeting as non-resectable. They had progression on chemotherapy, and they had more than 30 metastases, and they still did very well. Then we did a harder selection in the SECA-2 trial, and you see the 5-year survival was increased to 83%. If you look at the 10-year data of the transplanted patients, we can see that tumor diameter matters. metastasis above 5.5 centimeters had poor outcome. If they had progression of disease, they were poor outcome. CA levels above 80 had poor outcome. And if they were less than 2 years from the primary diagnosis, they had poor outcome. Then we wrote this Oslo score, which take this into matter, and you can score a patients from 0 to 4. If you have 0 to 1 points here, the 5-year survival is 75% and 10-year survival is 50% if you transport them. But there's a fundamental problem. This problem getting grafts for these kind of experimental indications. This led us to develop this a new concept where you can use the segment 2-3 to transport adult recipients with colorectal metastasis. We called it a rapid concept, where liver resection and partial liver segment 2-3 transplantation with delayed total hepatectomy. The principles are that you resect the left side to make space for segment 2-3 graft, and you keep the sufficient liver on the right side to avoid post-op liver failure. You transplant the segment 2-3 graft, you take the portal vein, move it over to your graft, and this leads to liver regeneration of your graft, and you monitor graft weekly, and finally do the right hepatectomy, and the patient can survive on only segment 2-3 grafts, which are more accessible and gives less morbidity to the donor than using a full liver or a graft from a next donor or the right side of graft, which is usually used in living donors. These are the IHBBA consensus guidelines. And as you see, extrahepatic metastatic disease rules out transplantation. The molecular criteria, BRAF mutations, are ruled out. They have poor outcome if you transplant them. MSI patients, they should have immunotherapy. Primary tumor pathology, there has to be done a radical resection. The node involvement is important. And we also don't transplant patients with signet ring cell differentiation. And I remember my time here at the Khanum in 2018. There were quite many actually young patients with colorectal cancer with signet ring cell differentiation, and we don't see that often in Norway actually. And right-sided primary tumors, they have poor outcome if you transplant them. They have to have a response on chemotherapy, at least 10% on RECIST criteria. Stable disease over time, CA level below 80. Then you can try to transplant them with good results. So state-of-the-art treatment algorithm presented here in 2020. If by colorectal metastasis, you have enough FLR, you can do a upfront resection, or you can do 2-stage hepatectomy. And if you have then multiple tumors, non-resectable, you can evaluate them for liver transplantation. And the final slide about next generation treatment. We also have developed a living biobank in Oslo for preclinical testing and drug testing. We moved the metastases from patients, and these metastases are grown in lab as small organoids, so patient-derived organoids. And then we hit these organoids with several 40 to 47 different drug combinations to find the right combination for this patient. We write a molecular tumor board report and give the patient the right treatment. We have included a few patients now, and this is really interesting, and we're just starting up now. So to sum up, number of liver resections are increasing. Their survival has improved. But should we be more aggressive with these patients? We see we can do more for this. The selection criteria is hard. And who should we resect? We have all these green islands, these gray islands. Liver transplantation is an excellent option for carefully selected patients. And drug screening on patient-derived organoids may direct us to more personalized chemotherapy. Thank you.
Thank you very much. Fascinating presentation and a great look into future. I think we'll take questions in the end just because of time. Sure. So if that's okay, we'll move on to our next speaker who's currently online. It's Dr. Gaurav Sen. It's a shame that he's not here physically with us today. I believe this is an on-call week. That's why he couldn't make it to Pakistan. So Gaurav is again waking up quite early in the morning to be with us. And he's going to talk about quite an important question about role of resection versus transplant for resource poor countries, because here transplant is quite an expensive hobby versus resection. So over to Gaurav for his talk.
Good morning, everybody. Can you see me from here?
Yes, we can see you, Gaurav, but thank you very much for being with us virtually.
Irfan, can you just clarify the recorded talk will be run, or do you want me to do it live from here?
A recorded talk. So is it possible if you can do it live?
Okay. Just to double check that you can see me, see the presentation.
Yes, we can.
Yeah. Good morning, everybody. Irfan, Faisal, thank you very much for inviting me to give a talk on a slightly controversial subject. And sorry about the confusion about the presentation, etc. I am wide awake. As you said, I'm on call and I've just come back from hospital to be able to be with you. I'm really sorry that I could not come physically because of on-call commitments and also some family commitments. I have got no disclosures to make, and I hope that I will find an opportunity at some point to be able to visit you guys in beautiful Lahore. I am, those of you who do not know me, is a consultant hepatobiliary and transplant surgeon at Freeman Hospital, which is the picture on the left-hand side. This is a hospital which has the only dedicated institute of transplantation in Europe, which houses all solid organ transplantation under one roof. We are involved in all cardiothoracic and all abdominal organ transplantation, and we as consultant abdominal organ transplant surgeons are involved in all organs, that is liver, kidney, and pancreas transplantation. Hepatocellular carcinoma, when we were trainees, and I started my training in neighboring India. I was born in Calcutta and I have been in the UK for 25 years. I definitely, as a trainee, wasn't so much aware of HCC being such a common cancer. And the present data suggests that this is the 5th most common cancer in men and 9th in women. As far as the cancer-related mortality is concerned, it is the 2nd most common cause of death from cancer worldwide. 10 years ago, in 2012, it accounted for nearly 750,000 deaths related to HCC, which constitutes about 10% of total cancer-related mortality in the world. Those of us who deal with HCC know that there is a wide geographical variation in incidence of this particular type of tumor, with the highest incidence in Southeast Asian countries. In general, prognosis is poor, mainly due to the fact that they are detected late and they do not have any specific symptoms, although patients who are high risk of developing them, i.e. the patients who have got background chronic liver disease, can have them detected early due to screening or surveillance programs followed in various different parts of the world. And once detected early, they do have a variety of treatment options. For small tumors, by which I arbitrarily define as less than 5 centimeters, there are options, and the options are mainly surgical with a curative intent. And by surgical options, I mean a combination of resection or ablation and liver transplantation, and they have all been shown to have very decent long-term disease-free and overall survival, which I'll talk about it in a minute. However, poor prognosis tumors like multifocal disease in the liver or large tumors of greater than 10 centimeters, the treatment options are a bit limited. And what is quite important is it is very variable depending on the resources of the country, and also depends on the state of the background chronic liver disease. In general, we have believed for a long time that surgery is the main pillar of treatment or curative treatment in HCC. Both resection and liver transplantation in selected patients have a very decent 5-year survival, up to about 70% and more, as my data will show later on. And it is the first option for treatment with a curative intent in patients who have got treatable disease. I will limit my discussion to treatable HCC, and I have not discussed anything about advanced disease or patients who need systemic treatment, because that's not the remit of this talk. And I'll try and compare the outcome of resection versus transplantation in a treatable HCC. I will try to touch on the ablative treatment for early HCC, both with the intention to treat with a curative intent or as a bridge to transplantation. I'll touch a little bit on the effect of resources available in different parts of the world in deciding the best treatment option. And I probably will be guided by people in the audience, including Faisal, my friend who has been in Pakistan performing liver transplantation, because the data about transplantation in resource-poor country is not very widely available. We have believed for a long time that liver resection is a preferred option for treatment for HCC when the liver function is well preserved. So as in non-cirrhotic patients or in patients with early child's A cirrhosis, whereas liver transplantation is probably preferred when the liver function is poor. And this is a sort of broad generalization, and even in 1999, Henri Bismuth published data regarding this. What are the options? I mean, so, how do we decide whether a patient should go down the route of resection or transplantation? Obviously, those of us who are transplant enthusiasts would want everybody to be transplanted, but that is not necessarily the right thing to do. The options are obviously, as I have already told you, resection, transplantation, or ablation, and in various different combinations of this. But in making the choice, I think the factors which become most important is the state of the background liver disease, or how bad the chronic liver disease is. Obviously, that's not the case in non-cirrhotic patients. Presence of portal hypertension is an important factor in patients who have got early cirrhosis or non-cirrhotic, where you are considering liver resection as the preferred form of surgical treatment. Then, of course, the tumor characteristics, that is the size, number, and location. And we should not forget about the fitness of the patient. In a very nice review published in 2019 by the group from Singapore, they talked about how do you choose between liver resection or liver transplantation, or what are the factors that affect this choice. First of all, just a quick reminder about the confirmation of diagnosis of HCC, because we are very heavily dependent on cross-sectional radiology in patients with cirrhosis for diagnosing HCC. We do not necessarily would biopsy them. So it is very important in countries like UK, where there is no indication for transplanting yet for other conditions like cholangiocarcinoma, that we are very sure that we are dealing with HCC, and strict radiological criteria with cross-sectional imaging involved is documented that we are dealing with HCC, along with raised tumor markers are documented. What is important for the choice of liver resection or transplantation is, first of all, to assess the background liver function using well-recognized scores. The one which we use in UK is UKELD, which is a modification of the MELD score. We need to look into the degree of portal hypertension with clinical evidence of it, including ascites, evidence of recurrent variceal bleeding, encephalopathy, etc. And in those whom we are considering resection with possible early cirrhotic disease, it is quite common for centers to measure the hepatic venous wedge pressure. Anything over 10 millimeter of mercury is considered to be high risk for postoperative mortality and morbidity, although it is an invasive test and it is not widely used. And the second factor is availability of donor liver, and that is, I think, the crucial factor which varies from country to country. And there is discussion later on about deceased donor versus living donor transplantation. And also very important, because it is at the end of the day an oncological procedure that we are trying to perform, is the long-term outcome, including the risk of recurrent disease. I will not talk too much about liver resection here, mainly because we are trying to kind of look into the comparison between resection and transplantation. So I'm not going to go into the details of various different strategies that can be used to make patients resectable. And my previous speaker has touched upon some of the strategies during discussion with colorectal metastasis. I think the main factors are, is it oncologically appropriate thing to do, a resection? As in, can we definitely achieve a margin negative resection and to achieve survival benefit? Talking about marginal negative resection, it is the next factor is the technical resectability. What is the location of the tumor? Does it involve the vascular inflow and outflow of the future liver remnant? And obviously, talking about the future liver remnant, the quality and the volume of it is perhaps the most important factor in assessing the technical resectability of the tumor. And last, as I mentioned, is the host factors, as in the fitness and for the surgery that we are proposing. If you see the pictures on the right-hand side, obviously the tumor on the top and the tumor on the bottom would need definitely different surgical strategies, even if both the patients were non-cirrhotic. What about liver transplantation? We have been doing liver transplantation for malignant disease knowingly or unknowingly for a very long period of time. Even in 1991, where the first long-term outcome of liver transplant for malignant liver tumors were published, which showed a variable benefit depending on the type of tumors, which is, those of us who are in liver transplantation, we know that that's obviously true. However, in 1996, when the group from Milan with Mazzaferro published the first, what is widely known in liver transplant circle as the Milan criteria, there was a major paradigm shift in how liver transplantation is used in HCC. The criteria, as we all know, include single tumor less than 5 centimeter or up to 3 lesions, all less than 3 centimeter in diameter, with no evidence of vascular invasion or extrahepatic disease. If you follow the strict criteria for putting patients onto cadaveric liver transplantation list, they had very significant and acceptably good survival with almost 83% recurrence-free survival after liver transplantation and more than 75% actuarial survival after 4 years, which was the original publication in 1996. However, the interesting thing is that when we list patients under Milan criteria, they wait in the waiting list for a cadaveric transplantation, and when they ultimately get transplanted, lots of the patients in the explant histology shows that they were at the point of transplantation were beyond Milan criteria due to progression of the disease while they have been on the transplant list. Their outcome wasn't really bad, and the general feeling was that the Milan criteria was too restrictive and was denying transplant to patients who might benefit from transplantation in the long term. The next popular criteria which came out of the general feeling that Milan criteria is restrictive is the UCSF criteria, which includes solitary tumors less than 6.5 centimeter and less than 3 nodules, with the largest one being less than 4.5 centimeter, with a total tumor diameter of if it is more than 1 nodule, the total tumor diameter needs to be less than 8 centimeter. This is definitely an expansion from the Milan. And with this criteria, the group from UCSF showed a survival rate of 90% at 1 year and over 75% again in 5 years, versus less than 50% survival for those who are beyond this UCSF criteria. And this criteria, as an expansion from Milan, is widely used in different countries for listing. However, there are challenges for liver transplantation, and one of the major challenges is organ allocation, because we know that it is a very, very precious organ for transplantation, and shortage of donor organ is a major factor. Access to cadaveric transplantation in HCC is therefore very variable depending on which country the patient is in and which part of the world. Different liver transplant programs use different weightage for a MELD score or equivalent listing score to HCC patients, so that they're not disadvantaged, which depends on the availability of the cadaveric organ in that particular transplant setting. The organ allocation, however, should appear to be fair for both HCC and non-HCC recipient. And at least in the UK, we regularly monitor through national bodies to see that the HCC patients are not being unduly favored or disadvantaged by the national allocation system. In countries with less cadaveric donation, living donor liver transplantation has become the main driver for liver transplantation for both HCC and non-HCC patients, with excellent results. But obviously, these ethical issues of doing a major operation on the donor for treating cancer on the recipient continues to be discussed. There are various different selection criteria for liver transplantation for HCC in different countries. I think commonest still continues to be Milan, with UCSF being widely used in different countries. UK uses a modified Milan criteria. And also is trying to expand using various different strategies for downstaging, which I'll mention later on. Doesn't matter whatever criteria we use, including the last one, the Japanese National Expanded Criteria, which includes inclusion for living donation, all seems to achieve more than 70 to 75% 5-year survival rate, which is kind of the benchmark for a successful transplant outcome for HCC. There are strategies which are used to keep these patients on liver transplant waiting list while they're waiting for an organ in the cadaveric setting. There's a significant risk of dropout from the liver transplant list because of progression of the disease, and we use different therapeutic strategies, including transarterial chemoembolization, ablation in the form of either radiofrequency or microwave. However, if you look at the present evidence, it does not suggest any significant reduction in the dropout rate for patients receiving any form of bridging therapy. However, I think most centers will consider bridging therapy because we are always anxious of the patients going beyond an acceptable criteria while waiting. If the patients are waiting for more than 6 months for cadaveric waiting list, most of us will use some form of ablation or TACE to try and keep the patient on the list. The other extension of the strategy is downstaging of HCC for liver transplantation. It is the same driver that lots of patients whom we were transplanting strictly in Milan at the time of their explant histology showed that they were beyond Milan, drove the strategy of actually downstaging patients who were beyond Milan criteria to within transplantable criteria. This is very much a problem in patients who are in countries which are dependent on cadaveric donation. Good long-term outcome of liver transplantation beyond Milan criteria more and more push for the strategy for downstaging. Prospective trials published, and again, mainly by the UCSF group on downstaging of HCC has shown a very comparable result of overall survival and recurrence rate after liver transplantation in patients, those who were beyond Milan and were downstage to Milan. However, the same group has shown that the dropout rate in waiting list is higher in downstage patients. Most of the centers would recommend the 3 to 6 months waiting time or observation time to make sure that we look at the biology of the disease and they do not suddenly progress within that period of observation to make sure that they are not a high-risk candidate for transplantation with high recurrence rate. I personally do not have any experience of living donor liver transplantation, and colleagues in the audience will have experience of this because our center doesn't do living donor liver transplantation. It is well accepted alternative to deceased donor transplantation in countries where deceased donation is not as common. The main controversy is, however, is there is a potential that patients beyond an acceptable criteria for that country may get transplanted in living donor transplantation, as there is not much of a waiting time. You need to have a suitable donor, complete assessment, and have transplantation. And this has probably led to the finding of higher recurrence rate for HCC after living donor liver transplantation in initial studies, because there was no waiting period to see the biology of the disease and how the patient's tumor is going to behave. However, recent evidence does not support that concern. Ethical questions remain about living donation in HCC, more so if the tumor is borderline or beyond criteria, because you are subjecting the donor to a high-risk procedure where the recurrence rate in the recipient can be quite high. Just to conclude, a few things about the long-term outcome of resection versus liver transplantation, and there is a fantastic meta-analysis published by the group from the Far East, including major centers in Japan, Taiwan, Korea, and Singapore, who have joined together to publish this meta-analysis. I don't want you to go through the whole lot of it, and I have summarized for the audience that the overall survival in all these studies have shown was for liver transplantation was higher compared to liver resection group. So you can argue that for surgically resectable disease within criteria, liver transplantation gives better overall survival. Liver resection had a threefold higher risk of recurrent disease compared to liver transplant recipient. So that is also goes in favor of liver transplantation, mainly because obviously after liver resection, you are still living behind the future liver remnant with the same risk factor for developing HCC that was there in the previous scenario when the patient had a resection. However, survival was similar between patients with a solitary disease who underwent liver resection and liver transplantation. So those who have a single tumor at explant did not seem to have a difference in survival. The survival after liver resection and transplantation was also similar in Asian centers where living donation is the main predominant driver of liver transplantation. But in North American and European trials, studies showed that the survival after liver transplantation was more than liver resection. So in conclusion, I would like to say that liver transplant does show a better long-term survival, although there is regional variation as the meta-analysis shows. Liver resection should be considered as the preferred treatment in non-cirrhotic livers or early cirrhotic livers with resectable HCC. I'm sorry that I haven't addressed the issue of liver resection versus liver transplantation in resource-poor countries because the data is very little. And most of the cost comparison compares the cost of liver transplantation versus resection without taking into account too much the cost of procurement of the organ in deceased donor setting and the cost of immunosuppression lifetime in patients who have undergone liver transplantation. So liver resection as such is a cheaper procedure if you just compare it with liver transplantation, and perhaps it should be considered more actively in resource-poor countries in non-cirrhotic and early cirrhotics. Access to cadaveric liver transplantation for HCC varies around the world, and obviously different countries use different strategies and offer transplantation depending on the resources. Living donation is definitely a safe option, has been shown very clearly in the last decade and a half, but runs the risk of being offered to patients beyond acceptable criteria. And increasingly, local regional therapies have developed a definite role in bridge to transplantation and downstaging, although the overall impact on survival and drop-off rate in cadaveric waiting list is not very clear. Thank you very much.
Gaurav, for being part of our meeting while you're on call. I hope it goes well for you the rest of the week. Just because of time, we need to move on to the next talk, but I'll email you or WhatsApp you any questions which come from the audience during the tea break. But thank you
very much.
Part of us. Thank you very much. Thanks. We'll move to the next talk, and Rob is going to tell us about how we have developed HPV surgery from open to minimal invasive and now to robotic. So what's the evolution of surgery for us as a surgical community? Over to Rob.
Thank you, Flanagan. The only disclosure I have is that I'm a keen laparoscopic surgeon. So I want to talk a little bit about the evidence that minimally invasive surgery is beneficial compared to open, and I think we're all aware of that. How new technologies are adopted in general and in surgery, and then about the evidence of the roles of laparoscopy and robotics in HPV surgery. So this is familiar to most of you. The advantages of minimal access surgery for the benefits of the patient, so less pain, reduced complications, less blood loss. For the surgeon, there are benefits. There's a magnified view in laparoscopic and in robotic surgery. Reduced hospital stay is a benefit to the surgeon and also to the hospital. But laparoscopy, on the other hand, is more difficult. There's a learning curve which is longer than in open surgery, and particularly for robotics, there's a cost implication. So if you compare laparoscopic versus robotics, the benefits are a little bit less clear, and we'll come on to this, come on to the data. Robotics may increase the feasibility of a minimally invasive approach for some procedures. It may reduce the risk of conversion. The advantage of a robot over laparoscopy is the wristed instruments, the 3D view, and the higher magnification, and you can sit down and have a cup of coffee while you're operating. The robot does have disadvantages. There's no haptic feedback, so anybody who's used a robot will know you need to develop visual haptics to compensate for that, and often you need two surgeons, one surgeon at the console and the other surgeon at the table. And the main disadvantage for the hospital is financial. So going from an open surgery to laparoscopic surgery is like climbing a mountain. You get a fantastic view at the top, but it's hard work to get there. I think going from laparoscopy to robotics is like getting a helicopter from one mountain to the next mountain. It's very expensive, and the benefits, and you get the same view whichever mountain you're on. If you look at technologies, how technologies are implemented, somebody has an idea for a new technology. There's a wave of excitement. Everyone thinks this is fantastic. So everyone starts using it. Then people realize this is not really very good, and then it goes out of fashion, or it becomes standard practice. So there's a peak of inflated expectation, trough of disillusionment, and then there's a slope of enlightenment. So in 1995, when I was a final year medical student, there was an innovation called the information superhighway, which some of you might recognize as the internet. And that's where it was at that point in 1995, when we know what's happened to the internet since then. If you apply that same evolution of technologies to laparoscopic HPV surgery, lap chole was first described in 1985. Not long after, lap liver resection in 1992, and laparoscopic Whipples was first described in 1994. So not very long after lap chole. Lap chole rapidly became standard of care worldwide. Lap liver resection is getting there, and lap Whipples or robotic Whipples is a long way off. Why is that? There are various triggers that can push a technology into practice, and there are various barriers which will prevent it. So the main trigger in healthcare is the benefits to the patient. So the benefits of laparoscopy we've already talked about, and they're clear if you're comparing open with laparoscopy. The benefits are less clear if you're talking about a transition from laparoscopy to robotic surgery. So it depends what procedure you're talking about. On the negative side, with two main detractors, two main barriers to implementation of a new technology. Clearly one is cost, and that's where the issue of cost with the robot is relevant. And then how complex the procedure is. And the complexity it includes the learning curve, how long the learning curve is, and how feasible the procedure is. If we take these three components and look at different common HPB procedures, clearly cholecystectomy has become standard practice laparoscopically. Now, for intermediate procedures, minor liver resection, distal pancreatectomy, there's level 1 evidence, which we'll come to, that there's a patient benefit over open surgery. Major hepatectomy, there is some evidence, and we'll come on to that. There's no data on high liver resections, lap versus open, and there is some data on lap versus open Whipples, which we'll come to. So it's lap minor hepatectomy, lots of studies. This is a systematic review of meta-analysis. So 13 randomized trials, 1,400 patients, benefit of lap minor hepatectomy versus open in terms of complications overall and severe, length of stay in hospital, and blood loss. So if it's feasible, you should do a minor hepatectomy laparoscopically. There's no question about it. For major hepatectomy, it's a more complex procedure with high morbidity. So the question is whether laparoscopy is better than open. We were involved in recruiting patients to the Orange 2+ trial, which was a European multi-center trial, randomizing patients, blinded trial, randomizing patients to open versus laparoscopic hemihepatectomy. The data has been published in abstract and it's awaiting full publication, but that essentially showed a shorter recovery, functional recovery from 5 days to 4 days, and a shorter length of stay from 6 days to 5 days. So these are statistically significant, but not dramatic. So there's a very modest benefit from laparoscopic major hepatectomy. But the learning curve was acceptable in this procedure. So distal pancreatectomy. So leopard trial, Dutch multi-center trial, small numbers of patients, but again, functional recovery beneficial in the laparoscopic groups at similar morbidity. The diploma trial, which is finished recruiting, was specifically for pancreatic cancer, so looking also at oncological elements, and that the data is not out for that trial yet. So laparoscopic Whipples. For the 4 randomized trials, the first 2 are single surgeon, single center trials, and importantly, they were not blinded, but they benefited a reduced length of hospital stay. What I want to draw your attention to is the length of hospital stay in the open group was significantly higher than we see in modern practice with enhanced recovery. We heard it earlier on, and patients weren't blinded. The trial, the Van Hilst trial, which is a Leopard 2 trial, Dutch multi-center trial, showed a high mortality in the laparoscopic group, and the trial was stopped early because of that. You look at the details of that trial. They allowed surgeons to recruit into the trial when they were still in the learning curve for a very complex procedure, laparoscopic Whipples, and so that's one thing to take away from that. That laparoscopic Whipples is a highly complex procedure. The latest trial published last year, biggest trial, 600 patients. Again, it wasn't blinded. It was statistically significant reduction in length of stay, but again, 16 days for an open Whipples is too long, in my opinion. The lap Whipples is feasible, but the benefits are uncertain. So this is a table of studies looking at learning curve for minimally invasive Whipples. The first 4 are laparoscopic, the second 4 are robotic. And the learning curve is long, even for robotic. And I just want to focus on the last one. So this is a huge number of patients, and they do 50 robotic Whipples a year. But even in that kind of center with high volume, they found that the learning curve was 100 patients for a robotic procedure. So even robotic Whipples it takes a long time to learn the procedure. So coming back to implementation of robotic HPB surgery, it depends where you're coming from, whether the standard procedure at present is laparoscopic or whether it's open. So if you compare lap to robotic, there's no data on gallbladders. for the intermediate procedures, minor hepatectomy, distal panc, and major hepatectomy. Transition from lap to robot, there's maybe feasibility data, but there's no evidence of benefit. No data on extended resection, and there's no data on Whipple's. So there are no randomized trial comparing lap versus robotic hepatectomy. We contributed to this multi-center international retrospective propensity matched analysis, looking at different types of liver resection. And the theme throughout all of the papers that have come out of this study were that robotic surgery associated with lower conversion rate than laparoscopy, but they didn't take into account learning curve. So that was, I think that's my major criticism of this data. Robot versus laparoscopic distal, no randomized trials. There's a meta-analysis of non-randomized trials, studies, 4,000 patients. And smaller tumors in the robotic group, which gives you an idea about the selection bias. But in general, the papers that have come out on robotic distal suggest that you can preserve the spleen in more cases and the conversion rate is less. But again, it depends on where you are in your laparoscopic experience. Whipple's, again, no published trials, but there are 2 ongoing trials. There was a study by Podder 2 years ago, 18 non-randomized studies, big numbers, 13,000 patients. But if you look at that, of the 13,000 patients, only 1,500 or 1,600 had a robotic procedure. It again tells you about the selection bias for a robotic procedure. Similar outcomes, longer operating time for the robot, slightly less blood loss. This was a study I referred to earlier on. They compared robotic versus open Whipple's. The comparison they did was after the learning curve, so that beyond the first 250 cases where they ascended the learning curve, and they found after propensity score matching, which is a method to try to reduce bias, they found less operating time with the robot, less blood loss, and less reduced length of hospital stay. But if you look at the length of stay, 22 versus 26 days in both arms. So it's difficult. Length of stay, in my view, is a very poor outcome, and it varies across different healthcares, different factors that affect it. So that's my talk. So in summary, the clinical benefits and acceptable learning curves justify a minimally invasive approach for minor hepatectomy and distal pancreatectomy. The added value of robotic over laparoscopy is limited, but it may shorten the learning curve for surgeons with limited laparoscopic experience. Laparoscopic major hepatectomy has a modest benefit, but due to its complexity should be restricted to experienced centers. The robotic approach may shorten the learning curve for major hepatectomy. There is insufficient data to confirm a clinical benefit with minimally invasive Whipple's compared to open surgery. Thank you very much.